Hello everyone, a very good morning. Today let's discuss on our most important topic, that is approach to a child with ataxia. So what is the definition of ataxia? So ataxia definition refers to a disturbance in the performance of your voluntary motor activities. So it's a disturbance in the smooth performance of your voluntary motor acts. So this disturbance in the voluntary motor acts is not attributed to any weakness or involuntary muscle activity. So this voluntary motor acts, that is the disturbance in the voluntary motor acts, cannot be attributed to any weakness or involuntary movements. Okay, next, what is the pathology behind an ataxia in a child? So ataxia in a child can be due to disorders either in a cerebellum or in a vestibular system or in your proprioceptive sensory system. How to distinguish the features of your cerebellar ataxia from your vestibular and your sensory ataxia? The difference is, in vestibular ataxia, it is characterized prominently by your vertigo. So vestibular ataxia is characterized by prominent vertigo, right? Next, it spares the limbs and the speech. It will spare limb and the speech. Well, coming on to your sensory ataxia, this sensory ataxia will be worsened during the darkness. So this sensory ataxia is worsened during darkness and when the vision is blocked, like in the rhombox. So the child will have a positive rhombox sign in this. Okay, when the vision is blocked, so the child will have a positive rhombox sign. Next, but it is also associated with a decreased joint position and vibration sense. So it is associated with a decreased joint position and vibration sense. Okay, this is how you differentiate your vestibular ataxia, sensory ataxia from your cerebellar ataxia. In cerebellar ataxia, what are the classical signs of your cerebellar dysfunction? So the classical signs of your cerebellar dysfunction are, first one is your titubation. Titubation is nothing but your bobbing or swaying of the head and trunk in your sitting position. So in sitting position, the child will be nodding or swaying the head, that is called as titubation. Next is your nystagmus. Nystagmus in eyes. It can be any horizontal nystagmus or a gaze evoked nystagmus. Okay. Third, the child will have dysarthria and pronunciation with normal language. Word count will be normal, meaning everything will be normal, but the child will have an unclear pronunciation, that is called a scanning type of speech in child with cerebellar dysfunction. The child will have dysmetria. What is dysmetria? Meaning errors in judging the distance. That is, when you do a finger-nose finger test, the child will either underestimate or overestimate the distance. Okay, that is either hyposhoot or hypershoot the point. Next, the child will have a post pointing. Next, the child can have intentional tremor. Next will be dysdiadochokinesia. Next is your drunk ataxia. Next one, the child can have wide-based gait, or also called as broad-based gait or a drunken gait. So the child will have a broad-based gait. And hypotonia will be present. Okay, so these are the main classical signs of a child with a cerebellar dysfunction. Next, here in this video we will see in a detail about our cerebellar ataxia. Cerebellar ataxia etiology can be either acute or chronic, right? So what is the meaning of acute? cerebellar ataxia. Acute meaning refers to symptom evaluation time of less than 72 hours. So the symptoms have been evaluated in this less than 3 days, so that is less than 72 hours. So this evaluation of symptoms of less than 72, meaning the child has acute ataxia. Next, the child can have either chronic ataxia. In chronic, it can be either static or it can be a progressive ataxia, right? Next classification is the cerebellar ataxia can be classified as either inherited or an acquired ataxia. So in inherited ataxia, the mode of inheritance is most commonly autosomal recessive. This is the most common mode of inheritance. But it can be autosomal dominant or mitochondrial mode of inheritance or X-linked. But most common is autosomal recessive. Next, in acquired ataxia, this acquired reasons are mainly, one is your drugs or toxins. Second one is your immune mediated or demyelinating. Third one, vascular. Fourth can be brain injury. Fifth can be due to plastic or paraneoplastic cells. Okay, so these are the reasons for your acute ataxia and your inherited ataxia. Next, we'll go into a detail of our acute ataxias. So we have seen the definition of acute ataxia, that is the ataxic symptoms evaluation time of less than 72 hours is called as your acute ataxia. What are the reasons, possible causes of your acute ataxia, etiology behind your acute? So causes of your acute ataxia, I'll tell the causes and a few important points behind each of the cause I will tell. Okay, first one is your infectious cause. So in infectious cause, most likely the infections are, it can be your varicella, Coxsackie virus, or it can be influenza virus, or it can be mycoplasma, or it can be a post-infectious also. Okay, so when you come to an infectious cause, here the onset of the symptoms, so onset of your symptoms will be sudden in onset, with truncal ataxia will be very severe. So truncal ataxia will be very severe in child with a cause of infectious disease. Next, prognosis is good. The child will have a good prognosis and the child will have a complete recovery. So the prognosis for complete recovery will be excellent. Next, it accounts for around nearly 40% of your childhood, all ataxias in children. Fine. Yes, most common age group occurring this will be around 2 to 4 years of age. So these are the main points regarding your infectious and post-infectious cause. Second reason or second cause of your acute ataxia is Adam. Okay, this Adam, we have dealt in a detail about our Adam in our one of our previous videos. So here it is mostly because of a history of viral infection or a vaccination that has been given 2 to 3 weeks earlier. So it can be due to either a history of viral infection or vaccination that has been given 2 to 3 weeks earlier, right? Yes. So here mainly these are associated with their altered sensorium, seizures and multifocal neurological deficits. So they have been associated with your altered sensorium, seizures and multifocal neurological deficits will be present. The treatment here will be your high dose steroids is the treatment of choice. Next, third reason, third cause of your acute ataxia is your drugs. So drugs is drugs or it can be toxins. So come to toxins, the toxins mainly are, first one is your thallium. Thallium is used occasionally as a pesticide. So this can also cause ataxia. Well, coming to drugs, your anticonvulsants. Your anticonvulsants such as your phenytoin, carbamazepine. These can cause ataxia even at the therapeutic level. So even at the therapeutic level, they can cause ataxia first. Second, your barbiturates. Your barbiturates and your benzodiazepids, they can cause ataxia at higher serum levels. Okay, so these and another one, dextromethorphan, your antihistamine, can also be reason for your ataxia. Fine. So this accounts for nearly 1/3 of all the childhood ataxias. So this ataxia is most often accompanied by your nystagmus, confusion, inappropriate behavior or inappropriate speech. So you should need a high index of suspicion for to diagnose that the child has got any drugs or toxins. Next, fourth cause of your ataxia is your Miller-Fisher variant of GBS. So it is your Miller-Fisher variant of your Guillain-Barré syndrome. Here, history of viral infection, diarrhea or vaccination 2 to 3 weeks prior to the onset of illness will be present. What is the triad of your Miller-Fisher variant? So the triad is your ataxia, ophthalmoplegia, and third one is your aerifixia. So this constitutes the triad of your Miller-Fisher variant of GBS. So the treatment for this will be your IVIG or plasmapheresis if indicated. Yes, in CSF, what will you see the definitive for definitive diagnosis in CSF? You will be looking for your cytoalbuminic dissociation. So because in GBS you will be having a cytoalbumino dissociation. Fine. Yes. Next, the fifth reason can be your vascular. This vasculation is most uncommon in your childhood. So you need MRI brain with MRI to suggest the diagnosis. Next will be your sixth one will be your opsoclonus myoclonus syndrome. So this opsoclonus myoclonus syndrome is a paraneoplastic one. So opsoclonus myoclonus Ataxia syndrome, it is a paraneoplastic, immune-mediated paraneoplastic phenomenon to your neuroblastoma. Fine. So it is immune-mediated paraneoplastic phenomenon to neuroblastoma. Fine. Yes, it can be usually present in toddlers or in a preschool children. So neurological symptoms can precede the tumors by a month or by 2. Okay, the treatment for this will be your immunotherapy will be the treatment for this, and plus surgical removal of your neuroblastoma along with chemotherapy. So this is about your causes of a child with a acute ataxia. Next, we are going into chronic ataxia. So this chronic ataxia mainly, that is chronic static ataxia. This chronic static ataxia is mainly, it is a congenital one. It is a congenital ataxia, right? Yes. So this congenital ataxia are most commonly caused by your genetic, and they can include your cerebellum and vermium agenesis and hypoplasia also. Okay, so for this congenital abnormalities, MRI will be your investigation of choice. So what are the congenital ataxia or causes of your congenital ataxia? That is, first will be your Chiari malformation. That is Arnold-Chiari malformation type 1 and type 2 both can cause your chronic static ataxia or called as congenital ataxia. In this Arnold-Chiari malformation type 2 is your classical one. Second one is your Dandy-Walker malformation. In the Dandy-Walker, the child will have a cerebellar vermis hypoplasia, so that the child will get a ataxic here. Third one, it can be Joubert syndrome and related disorders. So Joubert syndrome and related disorders, child can have an ataxic feature. Fourth, here in Joubert syndrome, it is mainly because of mutation in your primary ciliary protein genes. So mainly the mutation primary ciliary protein genes. So in Joubert syndrome, the most common or the distinct feature of your cerebellum and brainstem when you see it in an MRI is, the distinct feature is a molar sign. It is called molar, that will be seen in your MRI. Okay, right. Next will be your congenital disorders of glycosylation. Fourth can be your congenital distress of glycosylation. These are the reasons of your congenital ataxia or called as chronic static ataxia. Next we are going into the detail of our chronic progressive ataxia. Next will be your chronic progressive ataxia. This chronic progressive ataxia most commonly because of your brain tumors. So this occurs because of the brain tumor, that is mainly your cerebellar tumors. So brain tumors are important cause of your progressive ataxia. Around 50% of all your brain tumors arise from your brainstem or your cerebellum. So this posterior fossa tumors are usually present with your slowly progressive ataxia. So this can be your posterior fossa tumors, right? Next, another one brain tumor, important one, is your frontal lobe. Frontal lobe tumors can also cause ataxia. Why? How? What is the reason your frontal lobe tumors can cause ataxia? Why? Because it can this can disrupt the interruption of your association fibers, which can lead to ataxia. So your frontal lobe tumors can lead to a consequence of the association fiber. This is the reason why your lobe tumors can cause ataxia. So this is the reason for your chronic progressive ataxia. Okay. Next, we'll go into a detail of inherited ataxias. So in inherited ataxia, I will tell only a gist of our main points regarding following inherited ataxia, which are very important. Okay. So in inherited ataxias, first one is your Friedreich ataxia. So this Friedreich ataxia, what is the reason for your Friedreich ataxia? It is mainly because of your repeats, that is GAA repeats. Okay. Next, it is the most common inherited ataxia. The child will have an abnormal echo, ECG, and in your NCS there will be a axonal neuropathy. Next study, fine. Yes, and here the child will have a hypoactive knee and ankle reflex with an extensor plantar will be present. Along with this, the child will have a sensorineural hearing loss, cardiomyopathy, skeletal abnormalities also will be present. So treatment for this is you have to give the supplements like CoQ and antioxidants. You have to give the supplements. Only this can be your treatment options. That is, I'll write it here. Sorry. So it is the most common, and features are the child can have hypoactive or 10 minutes hypoactive knee and ankle reflexes. Second, the child can have sensory hearing loss. Third, the child will have cardiomyopathy and skeletal abnormalities, and the child is prone to get optic atrophy also. So these are the features of your Friedreich, main important features of your Friedreich ataxia. Next, second one of inherited ataxia is your ataxia telangiectasia. So in ataxia telangiectasia, here the telangiectasia will be present in your bulbar conjunctiva, or it can be present in pinna or in a soft palate also. Here the child will have a cerebellar atrophy. So why this ataxia occurs? Because of the cerebellar atrophy, and the child will have a reduced level of your IgA, IgE and Gg. So these immunoglobulins will be in a reduced quantity. Along with this, the child will have a serum alpha fetoprotein of more than 10 nanogram per ml. Right? So these are the main important points of your child with your ataxia telangiectasia. So here you can give amantadine or fluoxetine can be given. This fluoxetine may help the loss of balance and the impaired speech. So it can help the loss of balance and impaired speech. Next, third one is your A beta lipoproteinemia. So in A beta lipoproteinemia, it is mainly your microsomal triglyceride transfer protein will be a defective one. So the child will have the features of malabsorption, that is the child will have failure to thrive, steatorrhea. So features of malabsorption will be present. Child will have a cerebellar atrophy. Along with this, when you take a peripheral smear, you will notice acanthocytes in the peripheral smear. The child will have a peripheral neuropathy with cardiomegaly also will be present in this child. So the treatment for this child will be of supplements only vitamin E and other fat soluble vitamins can be given as supplements. So this is regarding your A beta lipoproteinemia. And fourth one is your Refsum disease. In Refsum disease, there is a defect in alpha oxidation of your phytanic acid. So there is a defect in alpha oxidation of your phytanic acid. Here the child will have night blindness, cataract, pigmentary retinopathy. Child will present with night blindness, cataract, neuropathy, peripheral neuropathy, and cardiac arrhythmia. Okay, and the dietary restriction of phytanic acid will be the treatment of choice for a child with your Refsum disease. So this is one of the few inherited disorders I have taken here. I have not gone into a full detail of this. Okay, next we'll go into a flow chart where you can get an approach of a child with an ataxia. So with the history and the clinical features. With a history and clinical features, you have to distinguish first whether it is a cerebellar cause or a non-cerebellar cause. So first it is whether cerebellar or a non-cerebellar cause. Non-cerebellar, you have to distinguish whether it is vestibular, because vestibular, the vertigo will be its prominent feature. In sensory ataxia, the child will have a decrease in joint position sense and in vibration sense, plus the child will have a positive rhomboxing. Coming to your cerebellar ataxia, you can classify it as either an inherited ataxia or it can be an acquired one. In inherited ataxia, you have two, one is autosomal dominant and another one is autosomal recessive. Autosomal recessive is the most common one. In autosomal recessive, Friedreich ataxia is the most common of all. You have to differentiate whether it is Friedreich ataxia or other. If it is not a Friedreich ataxia, then you have to go a blood examination for a blood smear, serum vitamin E levels, serum cholesterol levels, serum alpha protein levels, immunoglobulins level, and serum phytanic acid levels to differentiate the different kinds of your inherited ataxia that we have talked here. That is Refsum, or whether it is A beta lipoproteinemia or your ataxia telangiectasia. Next. Well, coming to your autosomal dominant disorder, you have to classify whether it is an episode, that is intermittent ataxia, or it is a continuous one. So when it is an intermittent ataxia, it can come into a type of episodic ataxia types 1 to 7. When it is not an episodic ataxia, it comes under the following of your spinocerebellar ataxia. Okay. Yes. When coming to your acute causes, we have already discussed our acquired causes, that is your toxins, your drugs. Second, your infectious cause or post-infectious cause, trauma, vascular cause, space occupying lesion like your tumor and abscess, and it can be either due to paraneoplastic syndrome, because that is for example your opsoclonus myoclonus ataxic syndrome due to your neuroblastoma. So this is how you approach a child with a ataxic feature. First you have to differentiate whether it is cerebellar or non-cerebellar. Then among cerebellar, whether it is an inherited or an acquired cause. In inherited, whether it is an autosomal dominant or an autosomal recessive one. From there we classify the child's ataxic symptoms according to their blood investigations. Thank you. This is how we finish our approach to a child with ataxia. In next video, let's discuss on refractory anemia. Okay, yes. And also many have asked about our NEET PG PYQ question. This also I will discuss. I will post today or by tomorrow. I will post this NEET PG PYQ, important PYQs and important topics. And I will post. Okay, thank you.